session. The next speaker is Dr. Satish Thomas. He'll be speaking on challenges in IOL power calculation in congenital cataracts. Over to you, Dr. Satish.
Thank you, Dr. Meena, and thank you, Dr. Laila, for giving me this opportunity. I'll be speaking on the challenges of IOL power calculation in congenital cataract. So I think what most of us in the audience will be more familiar with is how to do a biometry in an adult cataract. And so it will be good to think about what will be the differences when we have to deal with the pediatric IOL power calculation. The challenges in pediatric IOL power calculation are these. Most of them are summarized in this slide itself. One is the measurement errors. We know that children may not fixate very easily. They may not be very cooperative. The instruments that we use for measurement of both the axial length and the keratometry are all instruments which are designed for adults per se. And also they are designed usually for a sitting up position, and in these congenital cataracts we will be often measuring them in a supine position. So that can also cause measurement errors. There are anatomical differences in a pediatric, in a congenital cataract case as compared to an adult eye. The formulae that we use for biometry, they are all adult formulae. If we do a primary posterior capsulorhexis and anterior vitrectomy, it may affect the effective lens position that we anticipate at the end of the surgery. The target refraction for an adult cataract surgery we know is emmetropia, but in a child it is usually not emmetropia. And there can be an unpredictable myopic shift. We know that we are going to put it in a growing eye. There will be a myopic shift, but that can be very unpredictable. So these are all the challenges that we face in calculating the IOL power in congenital cataract. So beginning with the axial length measurement. We know that errors in axial length measurement affect the IOL power calculation the most because of that's how the formula is. And we know from the SRK formula that it will manifest as a 2.5 diopter per millimeter change in adults. But the same thing can become a 3.7 diopter error, a 1 millimeter error in calculation in short eyes, where the axial length is 20 millimeters or less. So it becomes very important. And optical biometry is usually not possible in these children. We know that optical biometry is superior to ultrasonic because we can get it along the visual axis. And then some of the other problems of the ultrasonic calculation are not there. So therefore, but we have to rely on the ultrasound measurement of axial length. So it's usually done in theater because we don't have, we need sedation or anesthesia in order to measure that. So usually it's done just before the surgery on table. And if we are going to do that, then the immersion technique is the best method of ultrasound measurement of axial length. If we don't have access to that, then we go by the regular method. The problem with that is there will be some amount of indentation of the cornea which can affect the axial length measurement. Therefore, take multiple readings and then screen out those readings where you have the maximum anterior chamber depth, where you have the least indentation of the cornea. So this is how you can reduce the errors of axial length measurement. Keratometry, again, it's usually done on table just before the surgery. So therefore, we need a handheld keratometer to do the measurement. Again, average out several readings because these really small eyes will have a very steep keratometry. Which will again flatten out as the child grows up. And try not to use the eye speculum because the speculum can alter the keratometry there. Alternatively, we can choose the IOL power which is not based on keratometry also, which is based on axial length alone. So these are how the errors of keratometry are avoided. Now coming to the pediatric IOL power, the challenge is that we are going to put a fixed power IOL for a growing eye. So if we choose an immetropic power when we are operating, then that risks a significant myopia when the eye finally matures in size. If we go for an early hypermetropia with the expectation that the eye will become immetropic during adulthood, then we are going to face the challenge of management of amblyopia. So both these approaches, either immetropia or early hyperopia, have their own pros and cons, and the best solution lies in finding a compromise between these two. So if we are going to undercorrect so that we eventually end up with the least power, how much do we undercorrect? There are two approaches. We can either undercorrect by a percentage or by an absolute value. For example, a 20% undercorrection or 10 diopter or 6 diopter undercorrection. There are tables for that. And of these, the former approach, the percentage undercorrection is more accurate. So these are some of the tables that are available. One of the earliest ones we are familiar with would be the Dahan's recommendation, where he said that in children below 2 years of age, you undercorrect by 20%, and between 2 and 8 years of age, undercorrect by 10%. There is this Indian study from RP Center by Dr. Coker, which showed that in Indian eyes, the progression of myopia isn't as much, and so they have recommended far lower numbers, which are here. Below 3 months, you would undercorrect by 20%, but at 2 years of age, only by 5%, and like that. The other recommendation for undercorrection is based on the absolute numbers by Enyedi et al. Here you have a rule of 7, where if the child is 1 year of age, then your target refraction is 6 diopters plus 6. 2 years of age, 7 minus 2, 5 diopters, and so on. So that's the rule of 7. And so this is another table again, slightly different from the Enyedi et al. And on your right hand side is that table which gives you what IOL power to put based on axial length alone. So all these tables are available. You also need to look at certain other factors like status of the fellow eye. In a child with a monoclinic cataract or a pseudophakic fellow eye, then we need to consider the refractive status of the fellow eye in order to minimize anisoconia and consequent amblyopia. When surgery will be done in both eyes, then we can go for a larger amount of hyperopia. Visual acuity. It is probably easier in the future to manage myopia than amblyopia. So keep that also as an important consideration. And if there is a dense amblyopia, then it might be better to leave less hyperopia to treat amblyopia. And if you know that the compliance is going to be poor, then again, err on the side of immetropia than hyperopia. Higher the IOL power, more the undercorrection is needed. And in microphthalmia, we may not get the high power of IOL that is required, so you can go for the highest available IOL power. So the last part of the presentation will be on which formulae to use. Again, as I told you before, most of these formulas that we have are all for the adults. And in the adults, these are the recommendations that I've shown you below. On these axial lengths, these are the best formulae that are there. But studies have shown that when we study them in pediatric eyes, really none of these rules that we can see in adults really apply in children. So different studies have shown that different formulae are more effective. I've just put it there. I'm not going to read those out. You cannot come out with any recommendation because one study will show one thing, the other study will show just the opposite. The infant aphakia treatment study, which is the largest trial on pediatric IOL implantation, showed that Holiday 1 and SRKT gave the minimum possible errors. But again, some of the other studies have shown other findings. So it is fair to say that any formula used will give accurate results only in 45 to 50% of the patients. It may be justifiable to continue using an appropriate combination of two single constant formulas and choosing the lowest power in children. So to conclude, IOL power calculation in congenital cataract is challenging due to a variety of reasons. We have to use a combination of techniques of both the measurement and the formulae in arriving at the IOL power. But more importantly, we have to use our knowledge of the growth of the eye, considerations of amblyopia, status of the other eye, and the compliance of the child to choose the best guesstimate power of the IOL. Thank you.
Thank you, Dr. Satish, for explaining the challenges we face in calculating IOL power.